Good morning, everybody, and welcome to our dialogue today. My name is Ndlovu, and I'll be moderating the discussion on behalf of the Institute of Public Administration of Canada, which is IPAC Nova Scotia, and also the Department of Politics at Acadia University. Welcome. Just so you know, in case you do not know what IPAC is the largest professional association for public servants across the country, with about 18 regional groups across Canada. So if you're not in Nova Scotia, you should be able to find one within your region. And you can be a member, or you can just sign up for updates for events such as this one. And also feel free to follow us on LinkedIn if you're interested as well. Today is March 21st, which is a day when we commemorate what they call the United Nations International Day of the Elimination of Racial Discrimination. It's also Human Rights Day today in South Africa. It's a day that not only calls for a reflection on the progress we have made, but also reminds us of the work that still lies ahead in the fight against racial injustice and inequality. This day marks the tragic events of March 21st, 1960, when 69 peaceful protesters at Sharpeville in South Africa were killed during a demonstration against apartheid past laws. This day serves as a reminder of the devastating consequences of racial discrimination, and we gather today to honor the resilience of those who have fought and continue to fight for the dignity, rights, and freedoms of all people, regardless of their race, ethnicity, or background. At this time, I would like to give you a brief background on or overview of our program for the day. We will have some welcome and introductions, and then some speaker presentations, about 5 to 10 minutes each. And then we'll have a panel discussion, audience QA. So if you have a question, feel free to drop it in the chat box. We'll get to it at some point during this presentation. At this time, I would like to call upon Auntie Darlene Peters-Copeland from Acadia University and a member of the Glooscap First Nation to offer a welcome to Mi'kmaq. Auntie Darlene.
Darlene Peters-Copeland here, and Kwai. I'd like to Jalasi welcome everybody to Mi'kmaq, land of the Mi'kmaq, and today is a very important day, with all the stuff that's happening and in the world and in our own country. So yes, it sounds like it's going to be a really good day and a lot of discussion on this, and a long journey. This is going to be a journey that we all have to deal with for the next 7 generations. So I'm not feeling good today, so I've got this cold that's going around, and I would have been there in person, but not today. So take care, everybody. Well, all. Are we frozen?
No, we're not. Are you done?
Oh. Yes, I'm done. Yes, sorry about that.
Thank you, Auntie Darlene. I appreciate that.
You're welcome.
Thank you. Before I begin and introduce our speakers for today, I just want to acknowledge that people of African descent have been in Nova Scotia for over 400 years. I honor and offer gratitude to those ancestors of African descent who have come to this land before me. I would like to now introduce our panel who have achieved a lot and are experts in their own fields, and I appreciate their time to be here today. I will introduce them first briefly. If in case you haven't had time to check through their biographies, feel free to do that, but I will just do it quickly and then we'll jump into our introductions. Firstly, I would like to welcome Dr. Samir Shaheen-Hussain. He's an associate professor in the Department of Pediatrics and an associate member of the School of Population and Global Health, both in the Faculty of Medicine and Health Sciences at McGill University. He works as a pediatric emergency physician. He has been involved in a number of social justice movements, including Indigenous solidarity, anti-police brutality, migrant justice organizing for over 2 decades. Our second presenter is Dr. Elle Jones, who is an author, poet, journalist, educator, and advocate. She was the 15th Nessus Chair in the Women's Studies at MSVU and holds a PhD in Cultural Studies from Queen's University. She is a 2-time Atlantic Journalism Award winner and recipient of the Burnley Rock Jones Human Rights Award. She was the Poet Laureate of Halifax in 2013 and 2015. I have Damilola Iduye, who is a senior instructor at Dalhousie University of Nursing and research scholar at the Healthy Populations Institute, improving the health outcomes of people of African descent flagship. She holds a Bachelor of Nursing Science from the University of Ibadan in Nigeria, a Master of Nursing focusing on health policy from Dalhousie University, and a Master of Public Health from the University of Edinburgh, Scotland. She's currently enrolled in a PhD program in Public Health Science at the Dalal Lana School of Public Health at the University of Toronto. As a Vanier scholar, her doctoral research lies at the intersection of race, ethnicity, policy, immigration and citizenship status, structural racism, and health. Rebekah Quach is a senior strategist, health equity at the Department of Health and Wellness for the Government of Nova Scotia. Rebekah's work focuses on the implementation of the province's health equity framework. Her approach is to create lasting, meaningful impact work that is grounded in evidence and informed by community. Prior to taking a role with the Nova Scotia Public Service, she had worked as a senior strategy planning advisor at the Ministry of Health and Long-Term Care in Ontario. And then I have my two last presenters who will do the presentation together, Dr. Beverly McKee. Dr. Beverly McKee holds a PhD from the University of Victoria, a dedicated healthcare professional. She has worked in numerous capacities from social policy and program analyst with First Nations, Inuit, and Métis organizations, as a government health care consultant, director of population health at the government of Nunavut, and also as a nurse practitioner from coast to coast to coast. She's currently an assistant professor with Cape Breton University, working at the New School of Nursing at Acadia University. And finally, Dr. Cynthia Alexander. She's a public policy analyst who teaches in the Department of Politics at Acadia University after earning a PhD at Queen's University. Cynthia has been working with and for Indigenous peoples for over 30 years. Most recently, in the fall of 2024, she served as the faculty lead on Reconciliation policy dialogue series at Acadia University with Indigenous leaders from across Canada. Cynthia has published 3 books and numerous academic articles. So before I go on to our first presenter, Dr. Samir, just a reminder again to the audience that we will have a section at the end for questions for any one of our presenters. So feel free to drop them in the chat and we'll get to them at some point. At this point, I would like to hand over to you, Dr. Samir.
Thank you, Talent. Thank you also to Darlene for welcoming us, and obviously for all the organizing work that goes into this. So many people behind the scenes. So I'm not going to talk about myself because you already introduced me, Talent, but I do think it's important just for me because I'm not where you are, just to acknowledge and recognize kind of where I'm coming from. So I'm a racialized second-generation settler, born to parents who immigrated here from South Asia, a region itself impacted by British colonialism. The place where I live and call home in Tiohtià:ke or Munyang, commonly known as Montreal, is located on the unceded lands and waters of the Kanien'kehá:ka Nation. Canada exists because of land theft and genocide against Indigenous peoples, and settlers continue to benefit from these violent colonial injustices to this day. The diversity, resistance, and resurgence of Indigenous peoples and nations across Turtle Island are vibrant and ongoing. My responsibilities as a racialized settler include commitments to being in direct opposition to colonial violence and striving to practice solidarity with Indigenous peoples by building relationships rooted in ethics of social justice and decolonization. These responsibilities exist in my life across and beyond professional and personal realms. They drive my actions as a clinician, as an organizer, as a community member, and they played a role in why I wrote Fighting for a Hand to Hold, Confronting Medical Colonialism Against Indigenous Children in Canada. So I actually wanted to start today, since this event is kind of being hosted on the East Coast, with I guess, something that happened at the McGill University Health Center in 2016, and came to the news, made headlines basically in 2017. And it's a story of Kimberly Glowad. I'm not sure if people here are aware of her story, but Kimberly Glowad was a Mi'kmaq woman from Burnt Church who was living in Montreal in 2016, started having abdominal pains, and went to the McGill University Health Center, the emergency department, and was basically, she did not have her Medicare card with her at the time. And so she was told that she would have to pay something like $1,400 to be able to access healthcare services. She did not have that money, as many people would not. And so she basically went home, kind of hoping that things would resolve or whatnot. And she actually died 6 weeks later at home from complications of what turned out to be liver cirrhosis. And so had she been seen at that time when she initially presented, it's very possible, including based on my discussions with the coroner of her case, that she would still, she would not have died at that time. And one thing that was really kind of shocking, there are many things shocking about what happened to her, but she had actually written a letter to her mom during the time that she was sick, that was only found in her, with her stuff afterwards. So it never got sent to her mom initially. And in the letter, she'd basically written, "No ID in Montreal, you may as well be an immigrant in Alabama." And the context here is that this was, during Trump's first reign as president, and so she was making clear links with what was happening in the U.S. in terms of the attacks on migrants there, as when she was able to making these connections as an indigenous person here. And as it turns out, her observation was very apt on multiple levels, certainly from a geopolitical context, but also because, as it turns out, the fact that she was told to pay $1,400 was actually a consequence of directives and policies at the level of the Quebec government that basically charges a 200% surcharge for medical care at hospitals or other health service centers for people who don't have Medicare. So if you're uninsured, you're basically going to pay 3 times the amount of what any given care supposedly costs the public healthcare system. All of these things are actually arbitrary on multiple levels because we don't really know how care costs are actually determined. But the point being is, for an emergency care at that time, the cost to the system, supposedly, the thinking was that it was around $550 or $600, which is why she was basically told to pay around $1,400 for to be seen in the emergency. And so we kind of saw with her, what happened to her was basically, as an Indigenous person who did not have her Medicare card, she was basically caught in the crosshairs or crossfire, basically, of government policies that were meant to target migrants, and so we kind of see how healthcare policies and migration policies sometimes can intersect in different ways, and in ways that are obviously very, very concerning in this case, because it had an impact on someone who was not even necessarily directly targeted by these policies. And I mentioned this just because this happened, the news of this came out in 2017, and it, I'm sure, like in retrospect, played a significant factor for me in the development of the Hand to Hold campaign that I'm going to talk very quickly about, to realize how healthcare policies have actually huge impacts, obviously, on populations, but how they can be politically motivated, clearly. And so, when we're talking about the Hand to Hold campaign, I'm not going to go, I don't have time, unfortunately, to go over all the details, but essentially, the context was that since the 1980s, the provincial medevac agency, Évacuation Aéromédicale du Québec, basically prevented parents or caregivers from accompanying their children during medevac airlifts from rural areas and distant areas. And this practice was applied across the province, but it disproportionately impacted Indigenous children from Northern Quebec. And so in January of 2018, we basically launched a campaign called the Hand to Hold campaign to put an end to this practice, basically to make sure that all children have a hand to hold during medevac airlifts. And the campaign had a lot of ups and downs. It had a lot of coverage in the province, but also across Canada. Andre Picard at the Globe and Mail wrote a very scathing opinion piece in support of the campaign and against the non-accompaniment rule. We were even asked to write a piece for The Guardian, so it had kind of international echoes. And during the campaign, there were a lot of ups and downs, basically. It lasted about 6 to 9 months. We were able to push enough so that the health minister at the time, Gaëtan Barrette, acknowledged within a few weeks of launching the campaign that things had to change after initially denying it. And then in July of 2018, they basically instituted an actual written policy, because up until this time, nothing was written, to actually allow for caregiver accompaniment. And since October of 2018, all children across Quebec are basically allowed to be accompanied by a parent or a caregiver. And what's important to note is that campaign, when we won, it was not only something that benefited Indigenous kids from Northern Quebec, but actually benefited kids from across the province, requiring medevac airlifts. So I'm just gonna, if it's possible, just play, I wanna play a 2-minute video clip just to give you a bit of context of the campaign and kind of what we were dealing with at the time.
Is it me or it doesn't have sound?
Yeah, I don't hear the sound either. I don't know if Muriel is able to play the sound.
someone will not be made allowed.
A rule that prevented sick children from traveling with their parents aboard medevac flights has been widely criticized in Quebec. After recent pushback, the government yielded and promised to let parents on board. At a community event at this mosque, the health minister was asked why that hasn't happened yet. CBC obtained a recording of his response, where he guaranteed someone intoxicated will be kicked off of a flight in the next 6 months.
Where someone will not be made allowed, not allowed to get on the plane. Why? Because no one agitated, drugged, under whatever influence would get on the plane. That will not happen. And that happens all the time.
Those words led to a chorus of condemnation.
To have comments like that by a minister is totally appalling and unacceptable. We're going to demand that the minister resign from his position.
The head of an organization that represents Inuit in Quebec's north says he needs to apologize, and I don't think that will be enough. He needs to go. The trust is gone. Barrette backpedaled today, at first saying that people wrongly assumed he'd been talking about Indigenous people when he meant it more generally. Then later he offered this as an apology.
I can understand the sensitivity of that and the reaction, and I apologize for that. I'm quite sorry about that, but at the end of the day, can we move on?
The Premier is standing in solidarity with his health minister as a provincial election looms.
I think he's sorry that his words have been interpreted that way. I suggest that we leave it there.
Barrette did call the mayor of Kuujjuaq to apologize. The mayor says he does not accept the apology. He's demanding that the minister resign immediately. Jayla Bernstein, CBC News, Montreal.
So I'll try to bring back my slides. Thank you. So I mean, I share that for a few reasons. For people who don't know, Gaétan Barrette is himself a physician. He's a radiologist. He was a former president of the Powerful Medical Specialists of Quebec Federation prior to becoming health minister. And so, the fact that he made these comments basically in complete impunity, because despite all the calls for his resignation, he stayed in position until the end of his term and was actually even reelected, even though his party was not, in October of 2018. So I think that's kind of, quite significant. And one of the other reasons I share this video is that we hear, towards the end that he said, at the end of the day, can we move on? And I think that's very important, because it's something that, even when I was a medical student, when I was a resident, even now as a staff physician, I hear those kinds of comments to this day. And I guess one of the things that's, really important to keep in mind is that, at the end of the day, we cannot just move on, because there are ongoing impacts of colonization, colonialism, and genocide in this country. And so that's critical to take into consideration and to actually address in a meaningful way. When the campaign was launched, like I said, in January of 2018, a couple of weeks after, there was a former pediatric resident who emailed me basically to say, I can't even recall all the times in my residency that I was in a situation where this policy affected a child I was taking care of. She wrote, "We knew it was a rule, we knew it was awful, and yet we just kept going." And I think this kind of really highlights the level of kind of complicity and active involvement in many ways that healthcare providers can play in health injustices that are in other ways kind of basically normalized. And one of the reasons why I ended up writing the book, because that was never an intention initially with the campaign launch, was basically to make sure that we no longer just keep going. And yet, 4 days after the book was launched, the world received the news of the death of Joyce Echaquan. For those of you who may not know, Joyce Echaquan was a 37-year-old Atikamekw woman, mother of 7 children, who went to the Joliette Hospital maybe couple 100 kilometers outside of Montreal for medical care, and was basically labeled as drug seeking or whatnot, and received horrific treatment, including sexist and racist comments that were hurled at her, that she ended up broadcasting via Facebook Live, because she was actually asking her family to come get her because she was so scared of the care she was receiving. And so this is a picture actually here of the coroner's inquiry into Joyce Echaquan's death that happened in May and June of 2021. And over here you see her, one of her younger kids, her eldest daughter, Marie Wasiana, and Carole Dubé, her partner. So Marie Wasiana and Carole Dubé testified at the coroner's inquiry, which is very, very powerful. And we heard during the coroner's inquiry, I was invited to testify as kind of an expert on medical colonialism, but the medical expert who testified, who was an emergency physician, Dr. Alain Vaudeboncoeur, basically said that her death was avoidable. And a few months later, when coroner Jeanne Kamel, who presided over the inquiry, when she released her report in response to a question by a journalist, she basically said that if Joyce Echaquan were white, she would still be alive. And Jeanne Kamel had a very important, her report and her recommendations are very, very important. Her first recommendation was actually that the Quebec government take actual measures to put an end to systemic racism, because the Quebec government continues to deny systemic racism as even existing in healthcare and more broadly. And while her recommendations are really important, I think it's also important to keep in mind this line that Cindy Blackstock has said in the past: mainly good intentions and conviction are not enough. It is what we do in our actions that is most important. And so I guess one thing that I'd want to get across maybe as a take home is for those who are listening in or joining us to look into and to read Joyce's Principle. So Joyce's Principle basically was developed by her family, her community of Manawana and the Atikamekw Nation, with kind of two main goals. So one is to guarantee to all Indigenous people the right of equitable access without any discrimination to all social and health services, as well as the right to enjoy the best possible physical, mental, emotional, and spiritual health. And it also requires the recognition and respect of Indigenous people's traditional and living knowledge in all aspects of health. And so this is something that's obviously really important for those of us who are in healthcare, who are in education. And one of the arguments that I often make when I'm doing these kinds of presentations is that, if Joyce's Principle was actually implemented, because if you take the time to read it, there's basically 6 axes or 6 pillars that Joyce's Principle is kind of focused on, including relationship with the public, with the government, healthcare establishments, education establishments, among others. Implementing Joyce's Principle in a meaningful way is not only going to improve healthcare services for Indigenous peoples, but it's actually going to cause a shift in culture that's significant enough to actually improve the healthcare for everyone. And so it's really in everyone's best interest for Joyce's Principle to be adopted. And then beyond, kind of the work that we do in classrooms and in hospital walls, inside hospital walls, I think what's also important is really to underscore supporting Indigenous-led movements for self-determination, for autonomy, and for sovereignty, including taking to the streets when necessary. Because one thing I think that's really important for me to highlight is that if it was not for the political and social shifts that happened as a result of Indigenous-led movements for the last 20 or 30 years, the campaign would not have been successful. It's really those shifts that allowed the campaign, in my opinion, to make it such that Indigenous children being sent alone in 2018 at the time was just became completely unacceptable. So I'll end it there. Thank you very much.
Thank you so much, Dr. Samir. I will now move on to our next speaker, Dr. L. Johns, I think is in the room.
Yes, can you all hear me online?
Yes.
Okay, everybody, good morning. I'm going to briefly touch on 3 areas I think are important. I'll try and be brief. I want to talk about carceral health, so health within prisons, anti-Blackness in the healthcare system, and finally, the connections to Palestine. So on February 22nd and 28th in Halifax, the Halifax Regional Police, during so-called wellness checks, killed 2 people with tasers. So we had that within a week. The East Coast Prison Justice Society, of which I'm a member, and I just want to pause for a minute and also acknowledge the passing of Harry Critchley, who was a member, very important member of that group for us. So we released a statement calling for the government to put an immediate moratorium on police being involved in wellness checks, and to yet again, and I say yet again because it's been reviewed multiple times in Halifax already, review the use of so-called less lethal weapons, which is the name for tasers, although they have been involved multiple times in deaths, particularly in wellness checks. So of course, people experiencing struggles with mental health, and that also, of course, often intersects with things like Indigenous status, racial status, refugees, etc. In fact, Nova Scotia has had many inquiries, beginning with the Howard Hyde inquiry in, I want to say, 2007, 2008, which was a man who was taken to custody in a mental crisis and died in the cells, again, through use of what they call conducted energy weapon. And at that point, there was a review, so we're talking at least 15 years ago, which made a number of recommendations that obviously have still not been implemented. Also in about 2008, Nova Scotia reviewed the use of conducted energy weapons because they've been used upon a minor during a wellness check again, and there were recommendations made that yet again were not implemented. Taser is in fact a brand name, it's like Band-Aid. So that's important because there's one company, Axon, that has a monopoly upon tasers. Their secondary product is police body cameras. So they both produce the weapons that the police use to kill people, and then the body cameras that liberals will tell you what is the solution to hold police accountable. So Axon's motto is actually protect life. And when tasers were first introduced, they were actually billed as non-lethal weapons. And then after they had been used in a number of deaths, they have changed that to less lethal weapons. And of course, they are not less lethal in any way. So I'm just going to pause this there. We can reflect on that. And of course, they are also used against minors, despite the fact that there has been no scientific testing of tasers on minors, because no one in their right mind is submitting a minor to have electric shocks put through their bodies. This also ties to a number of deaths in custody that have also occurred. Most recently, the deaths of 2 Mi'kmaq people, Peter Paul and Sarah Denny, who died in custody, provincial custody. Sarah Denny was having health problems before she was resent into custody, allegedly on bail violations. She repeatedly said that she was having problems with her health. She repeatedly called to be taken to the hospital. This is very similar to what we just heard. The prison staff said this was signs of withdrawal, drug use, etc. And she died of, I believe, severe kidney and liver failure, multiple organ failure. Her family has actually sued the province, and the health, whatever they're called, Nova Scotia Health, has responded by saying they had no duty of care to Sarah Denny as part of their defense, so that they were not negligent and that all duties were met, and that they essentially do not have a duty of care, despite the fact that Nova Scotia Health Authority has authority over prison. So this actually ties to the lack of health care in prisons in general. So I also want to say that Nova Scotia does not have mandatory or any reviews of deaths in custody. The last one we can think of is Howard Hyde. I don't think there's been one since. So when you die in custody in Nova Scotia, there is no requirement for any kind of review or inquiry into that death, which is, many provinces do have that. And in fact, a couple of years ago, I want to say 2018, sorry, I'm doing this off the top of my head, so I'm sorry if my date's wrong. When they changed the rules on reviewing deaths, they explicitly, even though people like Harry Critchley had campaigned explicitly to add deaths in custody, they explicitly left that out when they expanded it to include deaths in group homes, and they left out deaths in custody. So they had an opportunity to do so. So there's a deliberate refusal to account for deaths in custody, which tells you everything you need to know about how incarcerated people are treated. We know, of course, that incarceration intersects with indigeneity, with Black people, mental health, of course, the largest warehousing of people with mental health struggles is prisons. Disability, over 50% of incarcerated women are women with disabilities. Also, of course, things like queer and trans status, drug use, etc. These are all factors, poverty, that also intersect with incarceration. More than 50% of complaints now to the federal correctional investigator are health-based, and that has gone way up. We have tried, as part of East Coast Prison Justice, and as well Path Legal has tried habeas corpus in order to force prisons to produce healthcare, including dental care, which is actually a huge area in incarcerated people. Dental care is not considered necessary healthcare, and of course, anyone who's had dental pain knows it's the most debilitating pain in your. So people will be given maybe a Tylenol as they're dealing with dental pain. And there are many intersections that cause dental pain, such as people having houselessness, methadone, etc., that actually impact your teeth, nutrition, etc. So people in prison are much more likely to have dental problems that are not in any way covered. Prisons themselves, as we know from the COVID pandemic, are epidemiological sinks of disease. They transmit disease very quickly. We had a number of deaths in custody in the height of the COVID pandemic. There was a big campaign to release people from custody as a result. So prisons not only, of course, during something like a pandemic, but during any health event. If you've ever been inside a prison, you know that they are incredibly unhygienic. There's feces, there's mold, black mold, mice infestations, anything you can name. Prisons are extremely dirty. People are in extremely close contact. There's no air circulation, despite the fact that prisoners are supposed to be allowed outside at least half an hour a day under the Correctional Act. That is reduced to out of their cells rather than outside, so there's a lack of access to exercise and fresh air. When they are getting exercise, it is often literally in a cage, like a cage enclosed. If you see Burnside, it's like an enclosed concrete. I don't have a lot of time, so to talk to you constantly about the problems of healthcare in prison would be a very long speech, but I just want to tag that for us, that when we talk about colonial health, the deliberate removal of health services from people in prison as a so-called consequence of incarceration, which of course largely affects the most vulnerable people in society, we should pay attention to that, especially since nurses and doctors that have taken oaths for health will participate in prisons in either forced medication or removal of medication, strip searches. Nurses and such will stand by as people are pepper sprayed. People have been, forcibly strapped to chairs. We all know about the death of Ashley Smith, I hope, who died in custody in GBI as she put the sheets around her neck and the staff watched her expire for 45 minutes while they stood outside of her cell. It was, in fact, a member of the nursing staff who eventually revealed to her family what had happened and smuggled out the tapes, and she was the only person disciplined in the end. But we know that many of the medical staff and psychiatric staff in prisons are extremely complicit in this form of healthcare. So we need to call upon the Medical College of Surgeons, College of Doctors, and College of Nurses to not only set in strong guidelines, but to be willing to discipline medical staff who participate in the dehumanization of prisoners. Recently, we did have, for example, an emergency room doctor who basically said that prisoners deserve to die when they come into the emergency room. And when we complained about that, nothing happened. There was no discipline. So the colleges must have guidelines around what it means to actually provide healthcare in a carceral institution and stop deferring to security. I'll move on from that because I know I'm going to talk really long if I don't. The second thing I did want to address is anti-Black racism in the healthcare system. Obviously, as a Black person, I'd be remiss if I didn't raise that. I want to point you towards Dr. Amish Ray Dragon's recent book, Blood to Give, Anti-Black Racism and Homophobia in the blood donation system in Canada. So she is the James R. Johnson Chair of Black Studies, and she has recently published this book. So her work is on anti-Black racism in the healthcare system. We understand that this, of course, emerges from a long history of the dehumanization of Black people. We are quite literally treated as property. Studies of doctors show that doctors believe things such as Black people have a tougher skin, a higher tolerance to pain. So these ideas of animalization that emerge from slavery in a contemporary medical world continue to be believed by doctors. Doctors have very little, if any, education upon Black health. That can include things like, the APGAR scale they use for babies. Black babies often born with melanin spots. They will label children as a result of that, like, oh, it's a deformity, when it's a natural part of Black people's skin tones. They will use applications of scales relevant to white babies in order to assess Black babies. So on all these measures, you have racist measures applied to Black people. We heard also, of course, of how Indigenous people are treated in emergency rooms, and this is also Black people have similar experiences. We are labeled violent, resistant to care, drug seeking. You see many of the same narratives. Our medical schools in Canada all have a history. So Dalhousie, Queen's, McGill, all refused Black medical students. Queen's had a ban on Black medical students. It was not repealed until 2016 officially. McGill, of course, in fact, the father of the blood bank, as Dr. Mishre Dryden will tell us, the creation of plasma donation was a Black doctor, Dr. Charles Drew, who was educated at McGill, yet McGill consequently banned Black medical students, and Dalhousie did the same thing. So we have a long history within our medical schools and medical education of anti-Black racism and discrimination. That includes not only medical school, but within nursing, within dentistry. My friend was actually one of the first Black dentists to go to Dalhousie in many, many years. The admission standards continue to be racist. So I'll just acknowledge that. And of course, that history of anti-Black racism connects not only in the medical system, but also throughout our education, which is a matter of health as well. Literacy and education are incredible indicators of not only our future employment success, but things like incarceration. So when we think of criminalization, it is a health issue. And we should actually be thinking not through a criminal lens, but through a social health lens. So it's connected to many lenses in society. I know others are also going to talk about things like the child welfare system and the refugee system that also, of course, impacts Black people as well. But I will, in the interest of time, I finally want to say that in speaking about the colonization of the health system in Canada, we must acknowledge how this connects internationally, in particular in our current participation and complicity in genocide in Palestine. Speaking of the prison system, Canada has an MOU through the Department of Justice with the Israeli prison system that has stood since 2008, where we not only do exchanges, but are allegedly in a relationship with the system that by every report through Amnesty International, through the testimony of political prisoners, some of whom I heard when I was in Palestine recently, not only do they hold mass solitary confinement, we know 99% of Palestinians are imprisoned in the Israeli system. They have submitted to a different system, so system, which virtually imprisons everybody. We know minors are imprisoned without even a trial. Women. Many of us have heard of the torture camp Israel is currently running in the desert. Many of the Palestinian doctors have been tortured to death and raped to death in this essential concentration camp. Torture, beatings, sexual assault, all of this is recorded and documented to take place in Israeli prisons, yet we maintain an MOU with them. So this is a health issue. We cannot talk about the colonization of health while we continue to participate in starvation, in the blocking of aid, in the murder of unprecedented amount of doctors and healthcare workers, in the destruction of every single hospital in Gaza, the disappearance, torture, and kidnapping of doctors, the terrorizing of their families, all of which we have currently seen. I was heartened to see that yesterday 4 senators, but only 4 senators of the many, many senators and politicians we had, released a statement condemning Melanie Joly's recent statement, equally blaming Hamas and Israel for Israel's assumption of bombing the deaths of 400 at least Palestinians. Starvation, population, war crimes, they must stop the sale of weapons, and Israel must be sanctioned. But only 4 senators, including Senator Pate, the former head of Elizabeth Fry Society, signed on to that. So I'll just remind us that there can be no justice in Canada while we continue colonial and genocide actions abroad. And our silencing is also, I would suggest, a health issue, which I will finally say Audre Lorde tells us in the Cancer Diaries, where she talks about the impact. We know racism is a health issue. The impacts of racism have been very well studied to show how they impact us through health, high blood pressure, higher rates of heart disease. Black people's lifespan is literally shortened by 10 years due to the impact of racism. It's similar, of course, for Indigenous people in Canada as well. And that includes the silencing of racism. So that includes the stress of racism, includes when we must be silent about anti-Palestinian racism and its connections to anti-Blackness and anti-Indigeneity across the world. So we cannot, again, seek justice in Canada until Palestinians are also treated as human beings and allowed justice. And I will stop there and we will move on to the next person.
Thank you so much, Dr. L. Johns. I am going to quickly move on to the next person, being mindful of the time. Damilola Iduye.
Thank you. I'm just trying to share my screen. All right. Good morning, good afternoon, good evening, depending on where you're located. Thank you so much, IPAC and Acadia University, for this honor to be part of this great conversation on a very important day. Yes, the unfortunate event happened over 6 decades ago, but people of African descent, indigenous peoples, other racialized individuals continue to experience systemic discrimination, racism, xenophobia, hate of all sorts. And it's just quite unfortunate that we're still having this conversation many decades after that incident happened. And it still shows that we have a lot to do. We are still far from completing the work. So today I'll be talking more about confronting racism in the Canadian healthcare system, and I'll pivot a little bit to share an example of how I'm asking questions differently if we do confront and if we must confront systemic racism in the healthcare system. But before I do that, I want to situate myself as an African settler of Nigerian descent. And I like the opportunity to work, to live, and to play Mi'kmaq is something I don't take lightly. And it's an opportunity that I appreciate. And I also acknowledge my ancestors who had gone before me. And without their fight, without their struggle, someone like me would not be on this land today. So if we're talking about systemic racism, I just want to quickly contextualize the Black population in Canada. And I appreciate the previous speakers, Dr. Samir and Dr. L. Jones. You've provided great examples of how different population groups are impacted by systemic racism, by colonialism, by slavery, and all that. And for Black people, and this is something that we know, that we've been on this land even before Canada was formed. And out of all population groups, out of all racialized population groups, people of African descent or Black people are the only population group that we use color to describe in relation to the dominant population group. You have people from Asian, you have people from other countries. No other person is given red, yellow, or blue skin, but for some reason, and that's something we know why, people of African descent or African diaspora, we have different names. African Caribbean Black people, we are named based on the color. And one funny thing that happened when just the personal experience when my son was just like very, very young, was that he called himself brown and he called white people pink. And this was just a young child, 2, 3 years old, growing up in Canada. And when he heard white, he's like, no, mommy, they are not white. Like, and I'm not Black. Like, look at my skin. And that experience alone, like, just made me wonder, right, what was going through the mind of the individuals or a collective of individuals who thought a particular population group should be called Black, right? So I just wanted to preface what I want to share by saying that. And in my work, so I'm particularly looking at social structural determinants of health shaping the experiences of Black Canadians with type 2 diabetes. And the reason why I'm using this example as a way to contextualize how we can confront racism differently is because, one, Black Canadians, and this is something that we all know, are disproportionately affected by social determinants of health factors. So think about education, think about income, think about high unemployment rate, think about people who are housing insecure, think about people who are food insecure. And even for recent immigrants who were highly educated in their home countries, when they come here, they do not have jobs that match their educational level. So they are underemployed. They get jobs that they are de-skilled, if I must say that. And all of these have impact on the ability to have access to resources. So think about money, think about food, think about even having extra insurance apart from the provincial health coverage. And who when individuals do not have access to these resources, it impacts their lives, it impacts their family, it impacts their health. Different surveys, and something else that we do know is that Black people generally are underrepresented in medical research, but the findings that we do have, the evidence we do have, points to this direction that of all population groups, Indigenous peoples and Black Canadians are disproportionately affected. And when people don't have access to the resources that they need to live optimally, they face poorer health outcomes, and they also have inequitable health outcomes. And what happens is that these experiences contribute to their risk of chronic diseases, such as diabetes. And this is an example on this slide when I talk about different social determinants of health. So if you look at recent immigrants on this slide, you can see that of all population groups, so white, whether they are long-term immigrants or recent immigrants or non-immigrant, you can see that Black people are disproportionately affected in terms of their working conditions. So they work poor more than other population groups. But we cannot think about social determinants of health without looking at the root causes of health outcomes. And I really like this tree analogy, which I know that almost everybody in this room knows about. And this is what I'm using in my work. To improve health outcomes, we need to understand the mechanisms through which social determinants of health interact to cause health disparities and poorer health outcomes in Black Canadian populations. So if you look at the leaves, these are the things that we see. So we talk about hypertension, talk about diabetes, talk about obesity, talk about behavioral problems, talk about cancer, talk about all kinds of injury. These are the health outcomes that we see, and these health outcomes, this is what we know, that Black people are disproportionately affected. But we have to take a step deeper and look at the branches that gives nutrients to the leaves. And these are the common health behaviors. So you think about social connection. So for some immigrants coming to a new country without the family members, like it's isolating. You think about lack of exercise, you think about diet, you think about smoking, you think about substance use. But then all those things are still symptoms. When you look at the trunk, you see that the environment in which people live, in which people work, contribute.
Demi, sorry, can I disturb you? We cannot see the slides moving.
Oh, you can't?
No, we can't.
Oh, it's moving on my end.
Yeah, it's moving now.
Can you
so I'm
see
not.
Is it moving now?
Well, it's moved. We're now on the structural racism. Is that the one you're at?
Yeah, I'm here.
Okay, now we can see this slide.
Okay. Hopefully, please let me know if it doesn't move. Thank you.
Okay, and you just have 4 minutes left, just to let you know.
Yeah.
Thanks.
Yeah. So if you look at so I was talking about like the built environment, education, housing, the social environment, employment, all of this contributes to the fruits that we see in the leaves and the branches. But deep down, we have structural factors like structural racism, which we are talking about today, classism, we talk about distribution of resources, talk about slavery, talk about colonialism. So my question is, to treat people with that type 2 diabetes, can we achieve good health outcomes without looking at the root causes, right? So we know that they're disproportionately affected. We know that they face racism. We know that the high prevalence of social determinants of health contribute to poor outcomes in individuals with type 2 diabetes. And we also know that even people who have type 2 diabetes in our community, they have high mortality, they have high complications because of type 2 of the experiences of social determinants of health. But what we have not been talking about that much is how the social determinants of health intersect with structural factors. And because of that lack of recognition, many interventions have been focused on reducing weight, increasing physical activity, eating healthy food, adopting healthy life options like, okay, don't smoke, don't do this, don't do that. But we are not asking the right questions. So that's what I am talking about today. We cannot address systemic racism. We cannot improve health outcomes for people of African descent or Black Canadians if we're not looking at structural factors. We know that racism is historically and politically rooted. We know that racism against Black people is as a result of consequences of social construction of race. And evidence that we have do say that it impacts healthcare access. So lastly, in my work, I'm presenting type 2 diabetes as a health condition resulting from intersection of social and structural factors. And oftentimes we hear that if you're Black, if you're Indigenous, if you're from South Asian descent, you are at risk for type 2 diabetes. But the question I'm framing and I'm asking is, the claim of Blackness, does it really contribute to type 2 diabetes if we're not linking with social determinants of health? If we're not looking at the physiological risk factors such as obesity and stress, and this in itself is problematic. So lastly, can we discuss one without the other? Can we talk about social determinants of health? Can we talk about healthcare disparities without looking at structural factors? Both are interconnected. So in moving forward, we need to look at both. And that's why in my work, I'm looking at social structural determinants of health. So that's what I want to leave everybody with today. When you hear people talk about social determinants of health, think about structural factors feeding into those factors. Thank you.
Thank you so much, Demi. I appreciate such a wonderful presentation. And I'm sure a few of us are sad because we couldn't see some of your slides. And I didn't realize you were moving them. We're not moving them. But,
yeah, and my apologies. It was moving on my end, so I'm not sure why it wasn't moving on your end.
No problem. Thank you so much. We will now move to Rebekah Quach, who's going to present as well. Thank you. And over to you, Rebekah.
Thank you. And I believe just, yes, to make it a bit more seamless, or try to anyway, Muriel is going to move my slides, so you'll hear me say next slide. Hello, everyone. My name is Rebekah Quach. My pronouns are she, her. I'm of European settler ancestry, born here in Mi'kma'ki, and now I live in Chibukduk, or Halifax. I am coming to you from the Department of Health and Wellness, and just want to give you an overview today on the Nova Scotia's Health Equity Framework. And I'm humbled to have been invited here today amongst all these accomplished colleagues. And I'm very excited to be learning at the same time as presenting today. So thank you so much. Please forward to the next slide. Even the next one, thank you. By the end of this session, I hope that you'll have a deeper understanding of the Nova Scotia Health Equity Framework, have some insight into how we plan to implement it, its principles and its actions, and ideas about how it can strengthen partnership and improve health outcomes, particularly for underserved and underrepresented communities in Nova Scotia. And I was grateful for the questions that came forward about the panel. So what I don't address in as far as challenges or things that can be implemented to further strengthen, that will be in the panel discussion and questions Q&A. So thank you very much. Engagements on the Dismantling Hate and Racism Act, which passed in 2022, revealed serious racism and discrimination in the healthcare system. just an overview is that underrepresented communities experience poorer health outcomes due to unequal treatment and access. Healthcare staff from these communities also face racism and discrimination at work within the healthcare system. There are barriers to recruiting and promoting underrepresented groups and health professions. And the Action for Health strategy, and therefore the Action for Health strategy and the Dismantling Racism and Hate Act both called for a health equity framework to address these inequities. And so that's why that's the origin of this framework. So next slide, please. To develop the framework, engagement was heavily relied upon, as well as previous writings and reports that had already been published here in Nova Scotia. So we as a department and as a team collaborated with health system partners and communities. We held 75 engagement sessions. We gathered nearly 1,300 survey responses, and we reviewed best practices from other provinces and incorporated public feedback. And you can forward to the next slide as well. So slide 7, if you don't mind. Thank you so much. So after collating and coding the responses that came out of the engagement, 3 major themes rose to the surface, and none of them will surprise anyone on this call, I would imagine, is that patient experience was one of the major themes, with bias, stigma, and lack of cultural safety impacting care, quality, and trust in the Nova Scotia health system. Health human resources being the second theme. The workforce doesn't reflect the population's diversity, and we need more cultural competency and leadership diversity. And then finally, health system policy and practice. We need better engagement, data collection, and accountability to guide inclusive policies. So among those 3 themes, 35 actions were created, and they're listed throughout the Health Equity Framework. You can find the Health Equity Framework online. It is available. I can include it in as a link later in the chat as well. And so it's pretty much equally divided among those 35 actions, among the 3 themes. So you can move on to the next slide. So here it is. This is what it looks like. It was released in July of 2023. The framework provides direction for improving health equity in service delivery, programs, and operations. It's built on principles of equity, diversity, inclusion, reconciliation, and accessibility. So we call that ADIRA here in the health, rather than ADI, or we call it ADIRA because we add that reconciliation factor in as well. And also anti-racism and anti-oppression principles. As I mentioned, there are 35 specific actions. What we hope that this guide will provide is structure and direction for decision making on health equity in relation to service delivery programs and operations. It focuses on health system influences that are linked to health inequities, and it provides clear measurable outcomes with indicators and metrics to assess progress. I also just want to note here that in the framework up front, even in the minister's message, there is an acknowledgement of racism and discrimination in the healthcare system, and the recognition of a need for the anti-racism, anti-oppression, as well as ADIRA principles to address the discrimination and racism within our system. So you'll see here on slide 9, health equity work will only succeed with a critical mass of partners within our health system that understand the need to address it and have the tools, supports, and resources to make changes to their respective areas. So you can move on to the next slide, where I'm talking about, I hope it's big enough on your screens, but as far as implementation goes, so the framework is released, it is out there, it is there for anyone to use, and especially at individual organizational levels. But that acknowledgement that a system approach needs to be implemented as well is what has driven these 6 priorities for our focus on implementation here at the department, but with our partners within the health system as well, so health authorities and the various offices that touch on health care. So we're focusing on first a patient and family racism and discrimination reporting system. That is something that came out of the actions within the health equity framework, a workplace racism and discrimination action plan, a health workforce composition database, something that we don't have at this time and that we are developing together, a health equity collaborative, and that will bring about findings from research and create a partnership between the academic world, government world, as well as community to drive further findings and to be up to date in what needs to be addressed regarding health equity within the system. A health equity charter and infrastructure. So that is something we are embarking on this summer. And contact me if your organization is interested in the development and or signing at some point of a charter for health equity in Nova Scotia. And finally, centralized capacity building for health equity. These initiatives are in development, as I said, with government, community, and health system partners. And the way that we prioritize is we base it on the strengths of the themes from the health equity framework, the level of community need or acuity of the issue. If it is foundational and sets the stage for subsequent actions, so we have 35, but where do we start? These ones are the ones that were chosen because they will help create that foundation. They have significant potential to address gaps in data. That has been a large component of something that we're missing. That's a large gap, is specific data to know the indicators of success to create and then to be able to measure against them. And then it has significant potential for collaboration between our system partners in developing an approach. So that is why these 6 have been chosen as our first go at implementing as a system the health equity framework. So if we can move on, I found a few things that's related here to what we heard today, but especially as we were talking about, say, the justice system, the prison system in Nova Scotia, health equity extends well beyond the healthcare system. And we need broad partnership to strengthen innovation and ensure sustainable system-wide adoption. So that's why you'll see here that it is always in our mind that we are not just focusing on a healthcare system, that we do need partnership well beyond. So as justice and the prison system were mentioned, we have also been academia. We have extended and close partners, but everyone needs to be on board. And for example, when we develop our health equity charter, that is something that we will be sharing widely and creating opportunities for involvement beyond the healthcare system. So my final slide, yes. So our approach that I've outlined today focuses on building capacity, strengthening accountability, securing leadership commitment, generating evidence for better decision-making, engaging communities, and supporting innovation. Partnership is key, and we invite you to join in on this work. I would love to have connection with anyone who would like to connect with us to further explore ideas for collaboration and to be able to find our place, because everyone has a place in creating health equity. And if I'm talking to the folks on the call, the audience being public servants, we all have a place that we can start using tools like this. And I would say, as well as ensuring that they continue to be brought into conversations and made relevant at any level of work within the healthcare system. It doesn't just have to be leadership to be promoting. It can be at any level within the public service to use this as a grounding, as a foundation, as a reference in any documents that are put forward from your team. So thank you so much for the opportunity to speak, and I look forward to the next speakers.
Thank you so much, Rebecca. I appreciate timing that so perfectly. I will now move on to our final two speakers, Dr. Cynthia Alexander and Dr. Beverly McKee. Over to you.
Thank you so much. So grateful. So grateful to be gathered here in this virtual circle and in person gathering. A few of us here at the table at Acadia University, which rests on the unceded territory of the Mi'kmaq. Beverly and I are both settler scholars and citizens who are grateful for the generosity of being here and take our responsibilities professionally and personally to be good allies, including by working to disrupt dominant narratives, by working to unsettle structural barriers, and by working to address fiercely systemic discrimination and the ongoing medical colonialism, reflecting on the fact that two Indigenous scholars, Drs. Tyaki Alfred and Jeff Horntassel, remind us that colonialism has never ended, but instead what we're dealing with, in their words, is shape-shifting colonialism. As we look at this image on this screen, we may remember that Canadians are feeling a strong sense of national identity, raising flags, and we have, those of us who are settlers perhaps have not felt like doing so since the so-called Freedom Convoy, which we can remember had a strong anti-vax component to it, which directly relates to that. We will remember that almost every day we hear from our foreign minister, Melanie Joly, who reminds us that we have an existential threat, and that our prime minister has created what's being called as a wartime cabinet. But in the face of that, it's so critically important not to have excessive hubris, but to take this as another opportunity to look in the mirror and to look at what the Honorable Justice Murray Sinclair reminded us in 2014, that reconciliation is not an excuse to say to Indigenous peoples, get over it. And so if we can turn to the next slide, we've already heard about the structural determinants of health, and Beverly and I will work so hard to maybe try to do this in 6 minutes rather than 10 minutes so that we can have more time to chat. So we've heard about structural determinants of health, and when we look at the slide, I think the one message is that it's important to amplify Indigenous voices and Afrocentric voices. And I think we also need to include, as we've heard today, racialized peoples living in Canada, including those who are so-called migrants and new immigrants who face racism throughout our healthcare systems as well. We've chosen this image from the National Inuit Organization, Inuit Tapira Kanatami. It comes from 2014, but it shows that we need to amplify Indigenous voices. Since then, under structural determinants of health, for example, we would also include, as students at this table here at Acadia know, we would also include sovereignty. We would also include water. And so when we think about those structural determinants of health, we have to think that coast to coast to coast, we have Indigenous peoples and allies standing side by side, fighting, for example, along to protect to protect the land, all of which have been poisoned, for example, in the Alberta tar sands or oil sands. I'm from Alberta originally, and looking at the cancer rates among Native Athabascans, or looking at Chemical Valley in Ontario, or more closely, you may remember that it was Mi'kmaq together with Acadians and locals in Elsipogtog, New Brunswick, who stood side by side in the face of the militarized police, peacefully demonstrating against fracking because of the impacts on the land and the impacts that devastating land has upon our health. So if we turn to the next slide, we could look at any one of these social determinants of health and think, for example, of childhood food insecurity, just as one demonstration that this persists. I'm remembering Statistics Canada in 2006, There were headlines across this country that said that 40% of Inuit children are going to bed hungry. And where are we at today?
Today, we're sitting at over 80% of Inuit children. Nunavut has the highest child poverty rates, has the highest food insecurity. And so we question, we know about this. Why does this continue?
Excellent.
And so looking at this is a slide that was done in March of 2019. There was an apology, and yes, an apology is merited, with our former Prime Minister saying, today I'm here to say sorry. However, let's take a look at what also was going on in 2019. Nunavut had 170 cases per 100,000 of people who had TB. This was 290 to 300 times that of the remainder of the Canadian population, who had 0.5 cases per 100,000. So this persistence of TB in Inuit communities speaks to the persistent health inequity, and also speaks to the distraction of often Inuit people become blamed for the fact that they continue to have TB, as if they choose to have TB. So here we look at, we see the promises and the promotion of what? Photo opportunities for our government, the promise that TB will be eradicated by 2030. We're in 2025 and we haven't actually achieved a 50% decrease. And so we do lots of this as a distraction, as tokenism, and also to give a distorted perception of Inuit and health issues that somehow again continues this persistence of systemic racism and that shape-shifting of colonialism, which ends up blaming the populations that suffer the most.
And we could provide more examples, if we stick on that one for a second, but we could provide more examples of, the rhetoric, the commitments, the promises, let's study this, the apologies. I'm thinking, for example, that we've recently finally had an apology from the government of Canada to Inuit of Nunavut, and more recently to Inuit of Nunavik in northern Quebec for the slaughter of the sled dogs. Elders over the past 40 years have held it within themselves and have said this happened. And of course, that is one example of the RCMP slaughtering the sled dogs to remove the ability to be self-sufficient and to introduce forced dependence, which affects, for example, everything around those social determinants of health, including health and wellness. Today, March 21st, this UN Day is also a good day to remember that this is 2025. This is the 10th year of the TRC's final report and the 94 calls to action. The first 42 or so of those calls to action are related to justice, to health, to education, to child welfare. And I don't know if you've been following or have looked at the Yellowhead Institute, a policy think tank that's Indigenous-led. It's online in this country. Every year, two of our colleagues, one an Anishinaabe scholar who's at Toronto Metropolitan University in sociology, Dr. Eva Jewell, and a historian, a colleague, Dr. Ian Mosby, whose name you may know as well, who have been producing an annual report card on the calls to action from 2019 to 2024. And in the last report, they said it's futile because there is no action. There have only been 5 calls to action fully completed by the federal government, and that's in light of the 2015 commitment of the then Prime Minister to fully implement those 94 calls to action. We could, on the flip side of the coin, look at the Missing and Murdered and Indigenous Women's final report, and we'd see similar, not slow progress, it's just almost no progress, except for some jurisdictions. To quote Dr. Eva Jewell, who says, we also have to look at everyday colonialism, which we've had examples from our colleagues. And so Beverly and I, in 24, responding to our students' needs in a public policy classroom, we had a graduate student who left the room in tears and then came back, a bright, strong public official from Prince Edward Island, no less. And when she came back, she said, I thought I came here to learn. And what I've discovered from you in this classroom with each other is that I've got to spend a lot of time unlearning. And so that inspired this applied human rights framework that Beverly and I co-developed and have presented nationally and around the world to health professionals, to the World Health Organization in Tunisia, and use in our own classrooms. And at first we sketched this out left to right, horizontally. And of course, because we were looking at a personal, individual, decolonizing journal, creating a compass, it's not an easy journey. So we made it an upwards journey. What you'll see, and we can't talk about this for more than 20 more seconds, I think, is that there are 4 stages and 12 steps. And this also helps to unpack the guilt, the shame that we may feel that can paralyze us. And so the default mode, including in our universities, which have been slow to respond to the calls to action of the TRC, we're stuck in willful blindness, in mere tolerance, in mere awareness. And so that jump from the red zone to the green zone is the toughest one. And then it's a journey upwards. But for example, if you look at the curiosity about stage, there's a step called understanding of. And you could be a settler scholar and have a PhD having worked with or on still Indigenous peoples and still not give a darn, right? So that's why it's about building relations and connections at blue stage. And finally, there's that civic responsibility when we move to what a deepening, maturing democracy, rather than being delusional, even at that stage. Beverly, when we first designed this, we created it with the healthcare sector in mind. And you can see on the far left-hand side, just for example,
we can look at the dominance of the medical model, and that keeps us in that unfortunate state of being willfully blind to what's going on, as our speaker said before, of sending medevacs from northern Quebec with children without parents. Or a caregiver. That's willful blindness. You knew that this was wrong, but people continued. And so there's a need. If we move up towards the individual, professional, ethical, social justice responsibilities, this is taking, for example, at McGill University and creating a course about medical colonialism, the ongoing colonialism, neo-colonialism. And that too here for Acadia University is about designing a new nursing program that's not just looking at adding to, but using Indigenous knowledges, ways of being, and answering and calling, speaking to the TRC's calls to actions as a foundation, so that the nursing program can go forward in being inclusive and meeting the needs of Nova Scotians. And so we have that responsibility, that mode of engagement to move towards citizen responsibility.
And one of the things that we've done is we've tinkered with this because it's been so clear to us in the last 6 or 7 years this can apply to any major policy issue. And so remembering Senator Wanda Thomas Bernard, who spoke with my students and said, Cynthia, you really need to focus and introduce Afrocentric theory. And remembering, I've got a graduate student across me right now, remembering one of my graduate students, an international student who used Ubuntu as a theoretical foundation in that. One of the things we will point out on the far right side is this is a tough journey. So we conceived of this idea of a gravitational pull of the default mode. That may mean that there are colleagues or fellow students or family who don't support your own learning process and your own decolonization process. It may be challenging to look at the images from Gaza and the Gazification of the West Bank this week, but it's our obligation as global citizens. So we need to find ways to support our ongoing journal and recognize that sometimes we may take steps back, but we push forward. And as we do this, we go through a whole host of emotions. We don't have time to talk to this, but I think one of the things that we can remember is that we can use our anger, we can use our frustration as fuel to mobilize our individual and our collective decolonization actions.
And so in this, we have to feel discomfort. We have to step forward and say, how are we addressing human rights violations in and by Canada? Next slide.
And so one of the things that we want to do now, to start with a quotation from the Honorable Murray Sinclair, He says it's what we say in and about each other, in public and in private, that we need, there you go, oh, that's a reminder, that we need to look at change. And so it seems appropriate for the very last word, we invite a graduate student who's focusing his master's thesis on reconciliation, who's become a public figure on our campus and wrote an article in the student paper called Our Role in Reconciliation, A Better Word for Whom, and perhaps he can share this final quotation with you. Daniel Sonito Filho.
Thank you, Dr. Alexander. If it doesn't upset you, if it doesn't make you sad, if it doesn't make you want to fight, if it doesn't make you feel guilt, if it doesn't give you all of those feelings, then you are not doing enough. Then you are not pushing enough. Thank you.
Thank you so much, Dr. Beverly, Dr. Cynthia, and Daniel for those inspiring words. My apologies to our audience today. It looks like we do not have enough time for questions today. But I'm sure the people in the room will have plenty to discuss after we're done here. I just want to thank all our speakers who were able to make it today. I appreciate you sharing your insights, sharing your experience and your ideas with us. I'm sure a lot of us gained so much from today. I just want to end with these few words. Today, we've discussed racism, discrimination in healthcare, and these are not just issues on policy. These are issues that have to do with human dignity and equity. Every patient, regardless of their race, ethnicity, or background, deserves to receive care that is free from bias and prejudice. While significant strides have been made in recognizing these problems and beginning to address them, we know that the road ahead is very long, but progress is possible when we commit ourselves to it. We all come from different organizations. We work for, or maybe we're in academia. We all have a responsibility to do our part, as the last quote said. Whether it's a healthcare provider, a policymaker, or a patient, each of us must challenge ourselves, challenge our own biases, advocate for policies that will promote equity, and stand against discriminatory practices. This conversation should not end here. We must continue to engage in difficult but necessary conversations wherever we are, in our workplaces, in our families, in our communities, and hold ourselves accountable for making meaningful change. So happy March 21st to everybody, and I hope you gained something from our discussion today. If you have questions, I'm not sure how we can bring them, but you can find us on LinkedIn, and then if you need something from any of our speakers and need to connect with them, we might be able to do that. So thank you so much, everybody, and I hope you all have a good day today.